Hi and welcome. 1 in 4 individuals have been diagnosed with arthritis, and it is one of the leading causes of disability. So today we are going to talk about a comprehensive approach to treating and managing arthritis. Hi, my name is Dr. Arianne Missimer. I'm a functional medicine practitioner, doctor of physical therapy, registered dietitian, and I'm the owner of the Movement Paradigm Integrative Health Center in the Philadelphia area. I'm also a medical educator for Rupa Health. So let's dive in. We are going to talk today about what is arthritis, the pathophysiology, some of the causes, what functional lab testing can you do to diagnose, to treat, and manage arthritis over time. And then, of course, the most important part, which is how can we manage arthritis in our patients? So this could be through supplementation, nutrition, movement, exercise, stress reduction, and we're going to discuss some specialized treatments as well. So when we're thinking of statistics, 528 million people worldwide were living with osteoarthritis in 2019. And there's been an increase of 113% since 1990, which is astounding. The most common joint disorder in the U.S. is osteoarthritis. So it is something that we need to talk about. So what is arthritis? It's a group of more than 100 different diseases and conditions causing pain, swelling, and stiffness in the joints. Now, we are going to talk specifically about osteoarthritis today, but we do want to recognize that within this realm of 100 different conditions, we have things like rheumatoid arthritis, which is an autoimmune disorder causing inflammation in the joints. We have psoriatic arthritis, which is an autoimmune disorder, and also a skin condition that can cause joint inflammation. So when we're thinking of a standard inflammatory arthritis, it's going to be characterized by inflammation of the joints and tissues, often due to this autoimmune response. When we're thinking of degenerative arthritis, we're thinking of it involves the breakdown of cartilage and changes in bone leading to pain and stiffness. We can also have infectious arthritis, so this could be caused by a bacterial, viral, or fungal infection. And we can also have metabolic arthritis, and this could be caused by metabolic disorders such as gout, where the uric acid crystals can accumulate in the joints. So we're referring specifically to osteoarthritis. We want to think that this is the most common disease of the synovial joints in the hands, the knees, and the hips primarily, but obviously it can occur in any joint in the body. OA is characterized by the damage of the articular cartilage, the smooth, flexible tissue that cushions the ends of the bones within a joint. It can cause chronic inflammation in the joint tissues, and it can lead to this progressive loss of joint function, which means increased disability and reduced quality of life. So it is something that I have been working with patients for my entire career through physical therapy, more recently through functional medicine. And so it is something that we really need to understand at a deep level to be able to help our patients best and also be able to provide them with the proper recommendations. When we begin this breakdown or this degeneration of the joint, then it is going to affect so many other structures. So the ligaments, the tendons, the synovial fluid that lubricates the joints as the condition begins to advance. It's going to affect mostly these weight-bearing joints like our knees, hips, spines, hands, and even fingers. It's linked to aging, genetic factors. It's linked to injuries. So if we've had a past surgery or past injury, this can also speed up the process of degeneration. Excess mechanical stress on the joints from things like obesity, certain occupations, movement imbalances, and asymmetries over time. So we begin to have these movement compensations and then add to that load and repetitive use over time that can put a lot of extra stress and force through the joints that can cause potential degenerative changes. The current standard of OA is typically rehabilitation, so oftentimes we'll do PT to maintain joint mobility. Oftentimes a palliative treatment to manage pain, so often there's NSAIDs involved, there's steroids involved, and ultimately the eventual joint replacement is really the standard of care at that end stage disease. What are some of the signs and symptoms that we would see in our patients is joint pain for sure, stiffness. But I do want to just point out that some patients will report that they don't really have any pain in the joint itself, but when you're evaluating the patient, you will see that they have a tremendous amount of stiffness And that is affecting their movement quality overall. So that is a really big aspect of arthritis that I think is very imperative to look at, because I've evaluated so many patients where they might say, oh, I didn't even know, but then I'll suggest them getting an x-ray. And when they get the x-ray, then they realize very quickly that, first of all, the joint is extremely degenerative and it is causing so many other issues. So let's say at the hip, they might not have hip pain, but they have back pain and they have knee pain and so on. Limited range of motion is just what I referred to. Oftentimes you will see a localized swelling. So because of this inflammatory nature, you will see that they have localized swelling. Not in all cases. They might often have crepitus, so that's sometimes the noise that you might hear as the joint's moving through its range of motion. This could be quite severe in some people and non-existent in others. And just by listening to that sound does not mean that you have arthritis or that it's a problem. It's just something that may present along with these changes. You can also have muscle weakness. So especially when the joint is changing, that means that from a neuromuscular standpoint, that the tissues are going to start to fire differently. So if there's swelling, that's going to inhibit muscles. So you'll start to see a whole presentation of movement quality changing, and even joint deformities. So this can be really common as well, especially if we think of the knee, for example. We might start to see a genivarous position. So think of that bow-legged position. Could become very, very extreme in cases and often might be very noticeable. Or you can see enlargement of the joints depending on the type of arthritis. So what are some possible causes of osteoarthritis? So as I mentioned, we have cartilage breakdown. So this is the progressive loss of cartilage integrity due to an imbalance between the degradation and repair processes. So this can happen over time, and as I mentioned, from a lot of different reasons. We can have subchondral bone changes. So these are the structural alterations in the bone beneath the cartilage, affecting how we're able to load the joint properly. So when we're thinking about loading forces, I think that's important to understand, is that when we are striking the ground, we're going to encounter 1 to 1.5 times our body weight in force. If we are going to go into, let's say, running, that's going to be 3 to 4 times our body weight in force. If we go into jumping, approximately 8, and even in really high-level gymnasts, we might say up to 18 times our body weight in force that we're encountering. So if we don't have this ability to transmit forces well, then this can really begin to cause pain and disruption in everything. We have osteophyte formation, so the development of bone spurs that can cause pain and restrict movement. So oftentimes I'd like to think of osteophytes or calcifications. It's really a response that's happening from poor tensioning over time. The joint capsule and ligament changes. So we can have thickening, we can have reduced flexibility in the joint capsule surrounding the ligaments, and this can also limit the mobility. So then we begin to have this connective tissue issue as well. And last but not least is chronic low-grade inflammation. So inflammation of the synovium can release these inflammatory molecules, contributing to pain and damage. So what are some contributing factors to this? One, of course, is aging. But just because you're aging does not mean that you have to get arthritis. I think that is really important. My patients have told me for years that, oh, I'm just getting old. And I always tell them all of the things that they can do to manage this, to prevent this, to manage it. And it is multifactorial, which we will get into. Joint injury or overuse, there's always a genetic component because of structure, not because your mom had, let's say your mom had arthritis, so you're going to have arthritis. Now, in the case of autoimmune disease, yes, but if we're thinking of osteoarthritis, not necessarily. But the structure, their genetic structure, could absolutely be influencing yours or your patient's. Obesity, of course, this is weight and increased force through the joints is absolutely a huge factor. Poor joint biomechanics. So this is something that I'm always trying to help everyone move well and then move often. So if we have poor joint biomechanics over time, that's definitely going to make you more susceptible to this. And last but not least, again, is inflammatory triggers. So we want to think about all of the things that could potentially cause inflammation. So we have things like food, bugs, toxins, internal toxins, external toxins. We have trauma, and we have things like hormones. So we have so many different aspects within our gut and how this might attribute to the systemic inflammation and potentially localized inflammation. So speaking of gut, as it relates to emerging research, we want to recognize that there is a potential link between the gut bacteria composition and OA development or progression of the condition. When there's dysbiosis, there's a disruption in the gut microbiome, and that can affect the immune system, leading to systemic and joint inflammation. There can also be a metabolic influence. So, of course, we know that one of the key pathways of the gut-brain axis is our metabolic pathway. And so the gut bacteria can influence metabolic processes, impacting obesity and metabolic syndrome, thus contributing to OA risk. And then last but not least, we have microbial metabolites. So the production of anti-inflammatory molecules and short-chain fatty acids by the gut bacteria may influence joint health and inflammation pathways. So there's a lot of emerging research in this area and how osteoarthritis is also inflammatory in nature. And this is where we want to look beyond our simple measures of just looking at the joint itself and really looking at the whole person and how is their system and their innate and adaptive immunity able to respond to external stressors. So what are some functional lab tests that you can do with your patients to not only understand the root causes of the osteoarthritis in your patients, but also used for treatment efficacy? So the first are some inflammatory biomarkers. So we can use things like C-reactive protein and SED rate that can measure systemic inflammation related to OA and monitor treatment effectiveness. When we're thinking of differentiating potentially osteoarthritis from something like rheumatoid arthritis, we might look into something like rheumatoid factor or anti-cyclic citrullinated peptide, which can help differentiate OA from RA. Now, we can also look at a comprehensive stool test. We know that approximately 70% of our immune system is in our gut via the gut-associated lymphoid tissue. So the comprehensive stool test can be extremely valuable when we're thinking anything related to inflammation. And we know that the gut microbiome disruptions can contribute to joint inflammation and pain in rheumatic disorders. So comprehensive stool tests are going to look at so many different aspects of, is there a specific parasite? Is there an infection such as H. pylori? Do we have adequate secretory IgA? So the immune system of the gut. Is calprotectin elevated? We can look at all of the potential commensal bacteria. Are they in balance? Is the opportunistic bacteria elevated, in balance? And so we can really get a comprehensive look at what might be driving inflammation and begin to address some of the root causes. And then a nutritional assessment. And there are quite a few ways to do this, but if we're thinking of specialized testing, we can look at specific serum values and even red blood cell values. We can look at things like vitamin D, K, omega-3 fatty acids, because these deficiencies are actually linked to OA. We can do a more comprehensive look and something like the NutriVal test, which can be extremely valuable in looking at pathways, looking at metabolites, and really getting a comprehensive look at how all of these different nutrients are affecting so many different metabolic functions in the body. And so we can also do something like a chronometer. So we can have our patients do a week or 2 week analysis of what they're consuming so that we can really get an understanding of, are they deficient in certain things? Are they even getting an adequate intake of these certain nutrients? Whether it's through supplementation or through diet. So this is going to be such a huge foundation. So I encourage you to really get a system in place where you can, again, either evaluate them from their own nutrient analysis that they're doing and or also including other more objective data so that we can get a better sense of how they are really optimizing nutrients. And we can also look at things like food IgE and food IgG sensitivity testing. So that way we can really get an understanding if there's any potential food intolerances that are also contributing to a chronic low-grade inflammation. So what are the conventional treatments for osteoarthritis? So typically, as it relates to medications, it's oftentimes NSAIDs for pain and inflammation, and things like acetaminophen, which is Tylenol, or even Cymbalta for pain relief. And we know that this is not a good long-term solution. Not only does it potentially cause so many issues with gut health, which then can create further inflammation, but it also will affect pain perception. So the longer that we're on things like this, it can absolutely affect the way that we're able to regulate pain and inflammation. Invasive interventions like corticosteroids, even hyaluronic acid injections for more severe cases. And then, of course, therapies such as physical therapy, occupational therapy, depending on the situation. And then there is surgery. So joint replacements for persistent pain and disability of any of your major joints like your hip, your knee, and your shoulder, despite other failed conventional treatments. So what I would say here is that some people will still be on the path to get a joint replacement. And what we want to think of, though, is that when we see a patient experiencing especially multi-joint dysfunction, so when they say, I have knee pain and knee OA, and I have hand arthritis, and I have shoulder, then we're automatically thinking the systemic inflammation and what's happening and why is it happening. And so although someone still might be on that path, we really want to try to understand why they got on the path to begin with and how can we slow that down. So as it relates to a functional medicine comprehensive treatment protocol, we want to think about managing pain and symptoms, of course, balancing inflammation, and also, as I mentioned, preventing further injury and damage to the joints using these different lifestyle changes through nutrition, mind-body therapies, dietary supplements, and so on. So first, we've already talked about potentially doing a comprehensive stool test. I think this is really important for someone that is experiencing a lot of different inflammation and pain and disability. And so with that, we would identify whatever is happening in the gut and treat that specifically. So whether that is dysbiosis, it is leaky gut where they have increased intestinal permeability, increased LPS, lipopolysaccharides, that increased immune response that is creating that systemic inflammation. So we want to begin to treat that step by step depending on what's happening in their gut with specific evidence-based protocols. Next, we want to think about a therapeutic diet and nutritional considerations. So the main thing that we want to think about here is emphasizing an anti-inflammatory diet: fruits, vegetables, whole grains, nuts, seeds, lean proteins, fatty fish, with the key components definitely being omega-3s, antioxidants, and whole foods. So limiting these overly processed foods, a Mediterranean diet is a really good foundation. But we might want to consider a therapeutic food plan, such as an elimination diet, to see if there are any specific food sensitivities, potential food intolerances, or even food allergies. So it just depends on who you're working with, where they are in their journey, and if that's appropriate. But that really would be advisable if there's no history of an eating disorder or disordered eating, and they feel your patient is appropriate for a specific therapeutic food plan. However, if they are experiencing things like SIBO, small intestinal bacterial overgrowth, IMO, intestinal methanogen overgrowth, then we might be thinking of a specific FODMAP plan to reduce inflammation, reduce their symptoms, so that we can begin to heal their gut. And then also considering nutritional deficiencies. So based on your testing and your objective data, we can look at what are their deficiencies. So if they are super deficient in vitamin D, which is super common, then they could supplement with vitamin D, magnesium, and so on. When we're thinking of supplements, we're going to go through a few that can have shown to be helpful for arthritis. So the first is glucosamine sulfate. So this can help to maintain cartilage structure, function, and integrity. The efficacy does have mixed results, so I think that's important, but it is generally safe and it may alleviate pain and inflammation. Anecdotally, this is something that people do report having success with. So I think that that is also helpful, but it is important to recognize that there is mixed results in the literature. So we can combine this with chondroitin and omega-3 fatty acids that can increase the effectiveness. And the dosage for this would be 375 milligrams 3 to 4 times a day, and the duration would be 6 to 12 months. So these are things that we can look at over time and potentially retest in terms of medical symptom questionnaires. We can look at our objective labs. We can look at our functional lab testing to reassess. We also have collagen. So collagen is going to help support cartilage health and can alleviate symptoms. It can improve pain, stiffness, daily activities, and quality of life. And the dosage for this would be 10 grams of collagen, of type 2 collagen specifically, for the duration of 6 months. So collagen is made from animal or fish materials, and it's rich in amino acids that play an important role in building of joint cartilage, and it can have anti-inflammatory effects. So this, again, does have mixed results, so it is something to consider, but it can be helpful as a way to incorporate into the diet. Curcumin is anti-inflammatory, and it is an antioxidant, can reduce pain and the NSAID dependence. So this is a really great way to transition someone who is, let's say, addicted to NSAIDs and is taking them on a regular basis, taking them prophylactically. So I'm going to go play golf, so I'm going to take an NSAID. I can't tell you how many patients have told me that over the years. So I'm always trying to replace that and replace their patterns and their lifestyle changes. So oftentimes I will do that with curcumin. So this can help to protect cartilage, reduce pain, inhibit cartilage degrading enzymes. And the dosage for this would be 180 milligrams daily, and the duration for this would be 8 weeks. And then we have omega-3 fatty acids. So this is going to be our essential fats that modulate inflammation, support cartilage health, and improve joint function. It can help to reduce inflammation, protect cartilage, promote anti-inflammatory compounds, and contribute to pain relief. So this is one of the things that I would say right off the bat we would want to get someone on if they're not consuming fatty fish at least twice a week. So those sources really are going to be primarily our fatty fish, salmon, mackerel, sardines. It can also be things like our plant-based foods such as flax seeds, chia seeds, and walnuts, but we do want to keep in mind that that's much lower percentage compared to our fatty fish. And the dosage of this would be 1,500 to 2,000 milligrams daily. We do want to have it coming from a high-quality fish source, and this would be at the minimum 1 month, but really upwards of 3 months or even ongoing, depending on how your patients are responding. Movement and exercise. Of course, this is one of the most important aspects of managing arthritis. And this is something that as soon as someone starts to have arthritis and they have pain and they have stiffness, they don't want to do anything. And I could give you countless stories, success stories of getting patients to move safely and doing extremely well, regardless of what their joint looks like on an X-ray. So the benefits of this are reducing stiffness, improving overall function. When we're thinking of what exercise to do, it obviously will depend on the patient, on their preferences, on their ability overall. But some things that we want to think about are, let's say, first, strength training. So one of the most important things to do, a well-balanced strength training program is going to be key. And ideally, if someone is really struggling with a significant joint issue, then it might be really helpful to refer them to a very qualified personal trainer or fitness program that they are going to be monitored. They're going to understand what their movement is and how they can do exercises effectively without pain and only getting the benefits of that. We also want to consider things like low impact activity like swimming or cycling, even the elliptical, things that are not going to necessarily put a ton of stress on the joint, but it's going to keep it moving, and we can keep people active and work on all their other aspects of fitness. Things like mobility exercises. So I really love CARs, controlled articular rotations. So let's say that someone was experiencing a ton of arthritis in their neck. A controlled articular rotation would be beginning to articulate the joint in a very slow and intentional way that is ultimately loading the joints, but being able to increase that motion over time. So let's say that my neck was really, really stiff. If I were to do a neck car, I would start by having an upright posture, using my breath. You're trying to create irradiation in your body. So really strong posture, good tensioning. So I would bring my neck down and then begin to very, very, very slowly bring it in a circle, keeping the tension, maintaining my breath, coming back to center. And I would repeat that maybe 5 times on each side. Not a lot of reps, but really high quality reps. So different than if you were in an exercise class and you're just moving your neck around. And what we want to think of is that over time, we may be able to increase the mobility and how those joints are actually functioning and articulating. The exercise prescription should be extremely tailored to the individual needs. And the last most important piece of this is addressing biomechanics of why they've had this movement compensation over time. And I'll just give an example of something that I see quite frequently is when someone has, let's say, arthritis in their thumb. It's extremely common, see it all the time. Most often, they have a median nerve issue. So they have had neck issues for years and years and years, neck stiffness, neck pain, and they've had a median nerve issue, which has caused all of this weakness in their thumb over years and years and years, which now has developed into poor biomechanics and therefore an inflammatory type pattern of arthritis. So we want to get to the root of why that even happened. Or if someone's experiencing knee pain, knee arthritis, and they have a really poor foundation at their foot, we want to be thinking, how can we improve their foundation, their mechanics, and how they're interacting with the ground so that they can really begin to decrease this stress. And we can't forget about the mind-body connection. So I see this quite frequently when patients are experiencing significant arthritis, that there is often a nervous system component. And so we want to recognize and appreciate how stress contributes to inflammation. It changes even our microbiome, so we can increase our opportunistic bacteria and decrease our beneficial bacteria. So we want to be thinking about how we can incorporate some mind-body techniques into our patients' treatment plan. And that might be referring them, that might be suggesting something like yoga or somatics or breath work. But that is a really big part of this, because oftentimes what happens is our patients begin to identify with what's happening. So I can't do this because I have knee pain, because I have knee arthritis, because I have hip arthritis. And so we want to be able to reframe, we want to be able to help them really address the psychological component as well, so that they can begin to move their body as efficiently as possible through all of our recommendations. And the other thing I love to address with patients with arthritis is lymphatic work. So we know that blood vessels and lymphatics play a critical role in joint maintenance and could potentially affect OA development, progression, and even the rehabilitation. So if we think about our lymphatics as being, in my opinion, one of the most powerful yet neglected systems in our body, if we are experiencing inflammation around the knee, then we want to be thinking of the whole lymphatic system and how can we begin to really optimize how we are clearing some of these toxins and really optimizing our whole system. So when we're looking at lymph drainage, there's lots of different progressions of this, but we can think of it from the mechanoreceptor aspect, where we can do different techniques such as a feather light, faster, deeper, tap 1, 2, 3, and pull in the direction of our heart. So when we're doing that, we're influencing the mechanoreceptors in the skin, and the lymphatic system is just underneath of that. So we can use the left collarbone because most of our lymph drains on this side in the subclavian vein. So we can start with the left, go to the right, and we can go through all of these spots on this picture here. So we move all the way down, following the activity with a little bit of a bounce, a shake, qigong, to be able to really promote lymph drainage. When we have specific areas that have increased inflammation, we can get even a little bit more targeted. So for example, if there was knee OA, then we could have our patients do this technique, and then at the level of the knee, so the popliteal space where we have a lot of lymph, that's where they'll get Baker's cyst. So we can do some effleurage massage in the lower leg to really help optimize some of that swelling, especially after we've cleared the other key lymph areas. And then I typically recommend with my patients dry brushing at least 2 to 3 times a week, so they can alternate between this lymph drainage and then the next day performing dry brushing. And this could be really helpful in managing inflammation for these localized joints, because when they start to have more swelling, they start to have more pain and stiffness and more weakness. So it really just escalates a whole pattern. So if we can try to manage this, I think that's a really important aspect. And then as it relates to pain management, so of course there's pharmacological treatments and there's integrative treatments. So the non-pharmacological treatments can be things like acupuncture, physical therapy, hydrotherapy. And these are the things that we want to try to utilize as much as possible, as opposed to some of the common medications that I've already spoken about. So now let's touch on some of the specialized treatments that can be integrated into a comprehensive approach to managing arthritis. So the first is prolozone therapy. So this is a natural, non-invasive treatment that combines the principles of prolotherapy with the oxygen-boosting effects of ozone. So prolotherapy typically involves the injection of a solution of concentrated dextrose and other nutrients into the affected joint capsule to stimulate the body's natural healing process. So this typically will result in new growth of tissue, strengthening of ligaments, and even improved joint stability. Ozone therapy involves the injection of ozone gas into the affected joint, which increases blood flow and oxygenation, which can reduce inflammation and promote healing. So when combined, this prolozone therapy can be a powerful treatment in arthritis and chronic pain. However, once again, there are mixed results with this, so it is something that you can look at with a qualified provider who, may be very experienced in this, to see if it really is a good fit for you. The next is stem cell treatment. So where do stem cells come from? So the most common stem cell treatments used for arthritis are the mesenchymal stem cells. These are actually from the patient's fat, blood, or bone marrow. So the process of collecting the cells is typically called harvesting. So this, again, could be from the adipose tissue, from the peripheral blood stem cells, or the bone marrow stem cells. So bone marrow is usually taken from the pelvic bone, usually via a needle or a syringe, and it is bone marrow aspiration. So you're typically given a local anesthetic and even a sedative before the procedure. And then many medical physicians that are providing this are going to use medical imaging, such as an ultrasound, to deliver the cells precisely to the site of cartilage damage. So there are some cases with people with severe arthritis can benefit from stem cell therapy, but most research indicates that younger patients who have relatively mild arthritis or cartilage damage actually benefit the most. So this, again, is going to be with a qualified provider that is offering stem cell therapy. And then we have PRP. So this is platelet-rich therapy, which attempts to take advantage of the blood's natural healing processes and properties to repair damaged cartilage, tendons, ligaments, muscles, and even bone. So these are outpatient procedures. The patient's blood must be drawn and prepared for the injection. Anywhere from 45 to 90 minutes is the procedure. And the precision is extremely important. So it goes back to a qualified provider, being able to do this for your patients if you are not someone who is already doing it. And essentially the blood is drawn normally, and it's going to then be processed in a centrifuge machine. And using an ultrasound, it's going to be a small amount, it's going to be injected into the joint capsule specifically. So doctors who use PRP to treat osteoarthritis suggest that it can inhibit inflammation and slow down the progression of arthritis. It could stimulate the formation of new cartilage. increase the production of natural lubricating fluid in the joint, and so thereby it can decrease or ease that painful joint friction. And it can contain proteins that alter a patient's pain receptors that reduce pain sensations. So it could be all of these things per literature that a patient could experience, or none of these. And I have had numerous patients explore regenerative medicine, and I will say that there are definitely mixed results. So I think it really depends on the person, the doctor, provider that is doing it, the condition, the severity of the condition, and has your patient really addressed all of the other potential root causes, because the evidence on some of these regenerative practices is not always consistent. And so I think we want to really be thinking of it from a comprehensive approach. And then there's photobiomodulation. So this is known as, think photo is light, bio is life, and modulation is evoking change. So we're thinking of red light therapy or low-level therapy. This is a non-invasive medical treatment that utilizes specific wavelengths of red and near-infrared, specifically light, to stimulate cellular repair processes in the body. So it operates on the principle of photobiomodulation, where we have these specific wavelengths that are going to penetrate the skin, and they're absorbed by the mitochondria, so the energy powerhouse of the cell. And so this process, this interaction, is going to enhance cellular metabolism with the production of ATP, which is, of course, crucial for cell function. So by targeting very specific affected joints with these specific wavelengths of light, this therapy may stimulate the release of endorphins, the body's natural painkillers, and it can provide a relief from arthritis-related discomfort. So it can also be a very powerful tool, but there are a lot of different parameters based on the research of how much we need to use and the type of red light therapy. So there are a lot of different variables with this. And then, of course, we have lifestyle modifications. So it is imperative that we are talking to our patients about weight management, about sleep hygiene, about smoking cessation, or other lifestyle factors that may be playing a huge role in addition to the ones that we've already spoke about today. So when would we retest some of our biomarkers that we've discussed today? So in 6 to 12 week intervals. So if we are managing arthritis and you're doing some of these initial testing, you make recommendations, I think it would be really important to retest within that 6 to 12 week range to see if you're making changes from a biomarker standpoint, but also from a subjective standpoint. So this is where we can use our questionnaires to really understand how a patient is responding to our treatment recommendations. So I'd like to just finish with a quick case study. So a 53-year-old female that I had worked with who came in with a previous history of a tibial plateau fracture, and she was experiencing quite a bit of stiffness and swelling in her knee. And because of the stiffness and swelling, she was also having weakness, and she was also having quite a bit of discomfort, especially with dynamic activities. And so what we did, I wanted to kind of pull together all the things we talked about today, is I really looked at her from a comprehensive perspective. So of course, we needed to address the localized issue of what is happening at the level of the knee, the joint stiffness, the swelling, the pain, the weakness, and also all of her mechanical issues. So I always say there's always a mechanical component, so we still have to address that piece of it. So we did address that and looked at her movement quality. We optimized all of her movement patterns and really began to get her into more integrated movement overall, getting her back into exercise safely and very specific mobility work as it related to the knee, as it relates to not just flexion and extension of the knee, but also the knee rotation, which is one of the areas that we neglect quite frequently. While we were doing all that, we were addressing all of her other issues. So everything from looking at a comprehensive stool test and addressing very specific issues that we saw in her stool test. So definitely some inflammation, so low secretory IgA, high zonulin levels indicative of leaky gut, There was dysbiosis. So we addressed all of that. We also did an elimination diet, and that was extremely helpful for decreasing so much of her symptoms. So we also put her on some supplementation. So we put her on curcumin amongst some other very specific nutrient that she was deficient in. So we really took a comprehensive approach, an integrative approach to really looking at every aspect of why she was having limitations in the knee. And so she is doing great. So she is back to strength training 4 times a week. She is super active. She's walking, she's moving. And she was complaining of this for years, had been to multiple therapists. And so I think it's a really good example of how we can integrate all of these practices together. It's not necessarily one or the other. She needed some physical therapy, but she also really needed a very specific and targeted approach at addressing her as a person. And we needed to address a lot of systemic inflammation as well. So I hope that this was helpful for you today. I hope that you're able to take some nuggets and begin to look at arthritis from maybe a slightly different perspective. And if this was helpful, please make sure you like and subscribe to our YouTube channel for more videos like this on root cause medicine.
Welcome to Root Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.